Edwin C. Chapman, Doctor of Medicine, has practiced in Washington, D.C. for 40 years, specializing in internal medicine and addiction medicine. Currently, we are in a climate where things are a little bit tougher, resources are being pulled, and we're, as a medical institution, expecting or bracing for what's to come.
We're really fighting against a materialistic society where increasing someone's income is more important than saving lives. So we're really at a crossroads in our society as to who we are. Everyone should have access to health care, access to housing. Those are basic human rights. Universal health care is a necessity, and we can't rely on a for-profit health care system.
United States House of Representatives Committee on Ways and Means hearing on substance use, suicide risk in the American health system, March 2nd, 2022. Testimony of Edwin C. Chapman, Doctor of Medicine. Chairman Neal, Ranking Member Brady, and Committee, thank you for allowing me to participate in today's hearing. My name is Dr. Edwin C. Chapman, Sr. For the past 42 years, I have practiced internal medicine just 2 miles from the U.S. Capitol building. In 2000, I began treating patients suffering from opioid use disorder as the medical director of one of the 3 methadone clinics currently operated in the District of Columbia. It was there that I was introduced to the complex challenges faced by individuals and families confronting many issues, including access to mental health and substance use disorder services, housing discrimination, employment difficulties, criminal legal interference with the delivery of medical care, as well as multiple chronic physical health problems such as HIV/AIDS and hepatitis C. This unique, urban, disproportionately African American population generally began using opioids in the form of heroin, often having been introduced to it decades ago. As an internist, I was most struck by the needed services that these patients were not receiving, including psychiatric and psychological screenings, housing vouchers, and routine primary care preventive health services. Well, Dr. Edwin C. Chapman has practiced in Washington, D.C. for 40 years, specializing in internal medicine and addiction medicine. Over the past 20 years, he has investigated the complex mix of addiction, undertreated medical illness, infectious diseases, criminal behavior, and chronic diseases in patients who have 20 to 25 year shorter life expectancies. Dr. Chapman received his Bachelor of Science in 1969 and Doctor of Medicine in 1973 from Howard University College of Medicine. He completed his internship and residency in internal medicine as well as fellowship in cardiology from the historic Freedman's and Howard University hospitals. He's board certified by the American Board of Internal Medicine, the American Society of Addiction Medicine, and a fellow of the American Society of Addiction Medicine. He is also a member of the Alpha Omega Alpha Honor Medical Society, and he maintains an active membership in the National Medical Association and Medical Chirurgical Society of Washington. In the past years, Dr. Chapman has been featured in the Washington Post, Addiction Professional Magazine, NPR, Ebony Magazine, and multiple news outlets. He was recognized by the National Medical Association as their 2016 Practitioner of the Year. Using his medical training and research and patient care, Dr. Chapman exemplifies what it means to rebuild the village. And today we will be discussing all his impactful work. Please help me welcome the most amazing, well-read, and exceptional researcher and clinician, Dr. Chapman.
Thank you.
So welcome to the Transformed Minds. As you all know, this is the podcast where we're exploring the real-world intersection of mental health and addiction medicine. And we would like to transform all of these things that you're learning into your communities and your clinical settings. Again, I'm Dr. O. In each episode, we do the same thing. We take a thoughtful approach to what the clinical expertise in addiction medicine and psychiatric care is. Today is an expert RX where we have Dr. Chapman, and we'll be discussing a few of his work. Dr. Chapman, is there anything that I left out that you would like to tell us about yourself and about the work that you've done so far?
I actually was born in St. Louis, Missouri, but my family moved to Gary, Indiana, which is 30 miles from where we're located right now in Chicago.
Oh.
And that's where I grew up all the way through high school. And we really had an exceptional experience in education in Gary, primarily because of the exceptional principles and structure of our school system. Our principal at that time, for over 30 years, was Dr. H. Theo Tatum. And he was very instrumental in building the faculty at our high school, which included a number of educators who had PhDs and master's degrees from what are now commonly called historically black colleges and universities. So we had, in many instances, a college experience in high school because of that. To be here in Chicago, very close to home on this occasion, is special.
Oh, that's amazing. And it's such a small world that I will meet the president, who is also someone that you grew up with in Gary and shared some experiences with. And from what I'm hearing, you're saying you're where you are because of that early measures that were taken. You saw people that were exploring and showing clinical excellence or just expertise in the field, like they had PhDs, master's degrees. And it looks like that sort of influenced your decision on the path that you may have gone on, that academic excellence, which is very exemplified in your work.
Yeah, absolutely. Dr. Randall Morgan is actually the grandson of the principal, H.C.O. Tatum. You can see from his life experience, he's an orthopedic surgeon, and he was the 95th president of the National Medical Association. So following that, in the early 2000s, he was one of the founders of the W. Montague Cobb Institute, which is the research arm of the National Medical Association. So if you can imagine someone going on from orthopedic surgery to continuing medical education through the research arm for over 20 years, shows you what we're really talking about: lifelong learning and expanding those experiences to everyone in the community.
And it's just amazing to see both of you, see people that look like me, exemplify all of these expertise, and knowing that I can follow in the footsteps, and also to have you here to support the research that I am doing on my end. So thank you so much.
When you absolutely.
Talk about rebuilding the village.
Rebuilding the village. That's our theme.
Yeah. For your work, Dr. Chapman, one of the things that struck me was the urban model that you have, urban health model that literally emphasizes incorporated and integrated housing into substance use care or psychiatric care. You are an internist first, but you do a lot of mental health psychiatric services as well. Can you tell us a little bit about the origins of the urban health model and what that is for the people that do not know?
And so when we talk about healthcare, as health practitioners, we generally tend to talk to each other, physicians talking to physicians or administrators. But we found over 20 years ago, or maybe even before then, that what happens in the community is more important in many ways than what happens in the doctor's office or the hospital. So we've really identified the fact and talk about the fact that 80% of health outcomes are related to things that happen in the community, but we don't implement it. And that's the difference. So we decided at Howard University, in a sense, that if we're going to talk about it, we're going to have to do it. I was really out of the university setting and in the community for 25 years, and then began working in a methadone clinic, and worked in a methadone clinic for 12 years from the year 2000 to 2012. But then I was invited back to the Department of Psychiatry at Howard University. And I'm not a psychiatrist. The chair of psychiatry, Dr. William Lawson, had a vision because he was also working in substance abuse and mental health, and he was trying to really get the community health physicians and internal medicine physicians to understand the relationship. It may sound strange, have separated the head from the rest of the body. But now we're saying we know that the mind, what's in your head, really controls everything else. Blood pressure, diabetes, everything that we do. So we really had to reconnect those pieces. The other part was we had to reconnect the medical community to the community. So part of that model was going out into the community and actually reaching through our community organizations, particularly the Black faith community, in terms of understanding healthcare. So it was really educating the community to be health providers and to be health helpers, so to speak. And that's how the model came about. So we really worked very diligently in trying to educate the community. But at that time, it was AIDS was at the top of the list. And then shortly after that, they realized that AIDS and hepatitis C were also connected to the burgeoning opioid epidemic in our communities. So we had to educate the community to connect those dots so that we would then be able to move forward with them being partners in referrals and teaching as well as understanding the whole process.
Yeah, I think that's really important when you talk about not just saying things, but leading by example. And that's what yourself and the Howard community have been able to show with this model, is not just say these are the things that needs to be done to help the community, but actually put it into practice. And the other part of that is a lot of research and literature currently has shown that actually using the faith community, especially in minoritized populations where they find spirituality to be very important, it helps. And at least 50% of the time, that is their first contact when they're experiencing like a mental health crisis, substance use. That's where they may go, regardless of the stigma that may come with it. So I agree with you. That's amazing of how you guys have been able to do that, which brings me to the curiosity of understanding, how do you think, like in clinical practice, that the social determinants such as housing, transportation, access to insurance, healthcare, how does these affect treatment, and what impact does it have on patients?
Absolutely. So if you could imagine taking care of someone with a mental health problem or a substance abuse problem, and they don't have a roof over their head, they don't have a telephone, they're hungry, it's going to be very difficult to talk to them about taking some medicine. So we really have to be logical about our approach. And that's why we really brought the churches in, because the key component of this whole process is trust. If the community or if the individual does not trust the process, if they don't have living quarters, if they can't get food, then they're not going to take, why would they take medicine? Why would they be concerned about that? So we have to put things in order. Comfort, those are comfort issues. Being warm, not being hungry. You have to take care of those basic issues. Clothing, having a place to take a shower. All of those are very basic issues. Then you build that trusting relationship if you can provide those services. So that's why we focus on community or the social determinants of health.
Yeah, and from what you're saying, what I hear comes to mind is the Maslow's hierarchy of need, where when you look at it, at the bottom of that pyramid is really the basic needs that would help someone to psychologically function well in society. So
exactly.
If they don't need those, it's not going to really go well for
exactly.
them.
We have to put ourselves in the position of the patient.
Yeah.
And in many instances, we're taught we want you to take this medicine, we want you to take this pill, but that's not their priority. So once we understand that process and reverse it, then we can get that individual's trust.
Yeah. How do you think these sort of predictors help or worsen relapse in treatment? So let's say someone that they're homeless, unhoused in the street, they come in, they're really motivated to start treatment, but then they have to go back to the reality over and over again of being unhoused. How do you think that factor into the relapse of that treatment?
So in the District of Columbia, over 90% of our overdose patients are African Americans. And we know from the statistics that nationally, we're 13% of the population, but 37% of the unhoused. When we look at the opioid overdoses in the district, 30% of the overdoses are among the homeless. So that tells you immediately we could really lower those numbers just by housing people, because then that puts us in a position to easily contact them. If they're unhoused, they're very likely to have a mental health problem. They're very likely not to have access to communication and transportation. So that really lowers costs all the way around, because then you don't have to spend money to try to find the individuals.
As a clinician, what are some other ways that I can minimize these relapse? Because we know we can't provide housing, but there is a way that we could probably support in getting them those resources. So what are some of the steps based on your expertise that a clinician, social services, anyone that's in the healthcare field, what are the steps that we can take to assist and support?
So one of the models that we came up with, I give lectures also at Georgetown University, their addiction public policy and health program. Nice. And it's a master's program that was started by Regina LaBelle, who was the chief of staff for 8 years for the White House Office of National Drug Control Policy under the Obama administration. In 2017, they initiated that program. I met Regina and then became a lecturer every semester to that program. And one of the master students, we made a suggestion that we have these homeless encampments. Why don't we organize the homeless encampments like we organize post-Katrina, post-national disasters, where the National Guard or the Public Health Service comes in and creates a safe perimeter, brings in toilets, showers, clothes, everything that an individual would need, which would then give us an opportunity to, since we say we can't find the housing for them right away, we can at least organize that environment so that it's safe and comfortable for the individuals. Then we can triage people and find out what their mental health status is, what their substance abuse status is, what their economic status is. There's many people in those encampments just have an economic problem. They lost a job. But if they remain unhoused, then the other things like mental breakdown or substance abuse may follow. So we can really creatively do a much better job than we're doing in our cities around the country, where they frequently just go in and disperse the encampments, which from the medical literature makes the situation worse.
Yeah. And I completely agree with you. Like this, from that model, it sounds like we're already doing it. How about we take something that we know have worked in a different setting, apply it to this crisis that we're having? And I'm from New York. And if you know anything about New York, there's a lot of homelessness. It mirrors what happens in DC a little bit more. And a lot of them, like you mentioned, most of them, over 50% of them, have some form of mental illness, have some sort of substance use. And sometimes that sort of gets lumped into what's expected of them, the behavior that they may be displayed on the streets. But I'm like, what if we just provided the resources they needed? And currently, we are in a climate where things are a little bit tougher. Resources are being pulled, and we're, as a medical institution, expecting or bracing for what's to come. Are we going to see more homelessness and all of these things that we're experiencing, like the overdose deaths? How do you think, or has there been like a case that's really touched you that you've seen we could have taken these steps, prevented what happened in this case? And what are the roles for someone that's a trainee like myself that's seen a lot of homeless people that also come in with very severe mental illness and have comorbid substance use? What are some of the steps that I can take, if not even preventing that, to mitigate some of the harm or the risks that they may experience?
Yeah. Professor Eddie Glaude at Princeton University once told a story about a family. I think it was a grandmother and 2 children, and they had a cat and a dog, and the house burned down. So they came into the community immediately to rescue them. They immediately placed the house and the dog in the animal shelter, but they didn't know what to do with the grandmother and the children. What kind of society is that? Who are we as human beings that we don't have a process for immediately handling that kind of situation? So I think that really encapsulates what we're talking about, only on a larger scale. We walk past people laying on the street, and it's now become socially acceptable, so to speak. And I often think if Reverend Dr. Martin Luther King was here, that would be the number one focus of his concern. So as a physician, that disturbs me, and that is not who we are, or shouldn't be who we are. So when we really look now in our current environment, we're actually systematically talking about taking Medicaid and Medicare from people. That is inhumane. That is not the sign of a community that cares about people. So I think we're really fighting against a materialistic society where increasing someone's income is more important than saving lives. So we're really at a crossroads in our society as to who we are. Everyone should have access to health care, access to housing. Those are basic human rights.
And I completely agree with you. It seems like currently in our society, we're losing the empathy that we have for people, the compassion. And you mentioned how everyone should have access to health care. And yesterday, I was privileged to be at one of your talks. And one of the statistics that you were sharing was a comparison of where the United States falls in opioid use, overdose deaths compared to other countries, and why that may be. Would you be able to share a little bit of that with us?
Yes, if you really look at the Commonwealth Fund report, it shows that the United States far and away has the highest overdose death rate in the world. And I think that's a barometer for the failure of our healthcare system. 2 years ago, or the year before, they actually published a report that showed that we're 10th out of 10 countries in terms of access to healthcare and equity in healthcare. We're not supposed to use that word today, but we really have to, as a part of the National Medical Association and who we are going to continue to talk about equity, diversity, and inclusion. That is a human principle that we can't escape if we're going to continue to be a democratic society. Those are the facts, are that we're seeing it not just in substance abuse, but in overall life expectancy. So our life expectancy in this country is actually going down in many communities because of that. So the numbers are there. The facts are there that universal health care is a necessity, and we can't rely on a for-profit healthcare system where people see the idea of making money as the goal. We have to change the goal to good medical outcomes.
Yeah. There's like a huge disparity in the overdose that's happening when you look at race, age, and it looks like there is minority groups are having, even currently with the literature. Yesterday, we had a presentation where we were showing how we're looking at the TSA database, which for the past 16 years, and when you look at all the people in public assistance, the majority, Black people, are more likely to not have access to care. Native Americans are more likely to not have access to care. They're the ones dying more from overdose. And we're like, what is going on? Why are these people the ones that are getting affected more? If they are the chunk of the people that are experiencing this, why are they not having access to care? And that number even decreases even more when you look at young adults and adolescents between the ages of 18 and 25. It's about decrease over 50% of who has access to care. What are some of the things that you have seen, bringing it back to DC, and the things that you are doing for your community to help bridge that gap that can also be applied or modeled in other areas of the country?
So we know that there's a parallel outcomes with economics and health. There's just no question. A study that was published maybe 10 years ago by two Princeton economists, Ann Case and Angus Deaton, showed that within 5 years of the closure of an automobile assembly plant, for example, that there's a dramatic increase in alcoholism and overdose deaths. So there's a very close association. And then a study was done in Cecil County, Maryland. There was a automobile assembly plant in Delaware, right across the Delaware River. And they found that after the closure of that plant, that foster care in Cecil County increased dramatically. So what happened? Parents were separated from their children either due to drugs or incapacitated due to incarceration or death. So we're talking about this economics and an intergenerational component, because what's going to happen to those children in foster care? They then are faced with community stressors. So we know about what we call the pair of ACEs, adverse community environments and adverse childhood experiences. So we're actually creating that downward spiral. We're actually creating that demise of our, or implosion of our own community by not providing health care and housing to everyone. We're really talking about mental stress that all of us or any of us could experience. I don't know what it's to be homeless, but those patients of mine who have survived, the reason why I work so hard for them because of their resilience, the fact that they're special, the fact that they're able to go through all of that. You see some amazing stories, the most amazing stories. So why can't we apply that to everyone?
Yeah, I wanted to also make sure this was something that anyone that's listening, whether you are a healthcare professional, a physician, student, someone with lived experience, or even a family member, you're able to get something out of it. Thank you so much for coming, Dr. Chapman.